Thank you for joining us today. I'm Robin Whitney. I'm the Program Director of the Canadian Epilepsy Teaching Network. Today, I have the pleasure of introducing a friend and colleague, Dr. Suvasini Sharma. Dr. Sharma completed her medical degree and post-grad training in New Delhi, India, and she completed her pediatric neurology residency at the All India Institute of Medical Sciences in New Delhi. She worked at Lady Hardinge Medical College in New Delhi as an academic clinician for over 14 years and recently joined the Hospital for Sick Children as a staff neurologist and epileptologist. Her clinical and research interests include the ketogenic diet, infantile epileptic spasms, and sudden unexpected death in epilepsy. She is a member of the International League Against Epilepsy SUDEP Task Force. She has over 250 publications, and she's been the recipient of several clinical and research excellence awards, including the Sheila Wallace Award and the Bernard D'Souza Child Neurology Society Award. And today, Dr. Sharma is going to be speaking about evolving treatments in infantile epileptic spasms. So thank you all for joining us today, and a warm welcome to Dr. Sharma for agreeing to present. We really appreciate it.
Thank you, Robin.
There's like a black box just at the top. Yeah. Yeah, that's better.
Are my slides visible?
Yeah.
Okay. So thank you, Robin, for giving me the invitation to talk in this prestigious forum. I will talk about the current and evolving treatment strategies in infantile spasms. I have no disclosures. The learning objectives of today's session are to learn about the recent advances in the definitions, diagnostic criteria, diagnostic evaluation, and current treatment options and guidelines, and what are the new treatments in the pipeline. So I'll start with a brief historic overview. It was 183 years ago. This syndrome has been there for like almost 2 centuries now. Dr. W.J. West from UK, Turnbridge, he described this condition in his own little boy as a peculiar form of infantile convulsions, and it was published as a letter to the editor in Lancet. And subsequently, many child neurologists of the era recognized these spasms occurring in children with developmental delay. But it wasn't till more than 100 years later, in 1960, when the eponym West syndrome was suggested by the French neurologist Gaston. Gibbs and Gibbs, the EEG power couple, described hypsarrhythmia as the characteristic finding in 1952. It was soon recognized that not all children have hypsarrhythmia, but many have modifications, and the modified hypsarrhythmia term was given by Bowers and Jevons. And in 1958, even before the term West syndrome was given, the spectacular effectiveness of ACTH for this condition was described by Sorrell and Dorsassi-Boyer. So this syndrome has been there for like a long time, and it's been recognized. Some changes have come up. Like in the last few years, it has been recognized that spasms can occur in older children as well, and not just in infants. And many conditions, even non-epileptic conditions, can look like spasms. So we specify them as epileptic spasms and not infantile spasms. They are a very peculiar seizure type, and mostly they are seen in young children. They superficially look like myoclonic jerks, but they're different. So spasms last typically 0.5 to 2 seconds. They have a tonic phase followed by relaxation phase, which typically looks like a diamond shape on the EMG. If EMG is done along with the EEG, they typically occur in clusters, and they typically have a relationship with the sleep-wake cycle that they will increase when the child is waking up from sleep or the child is going to sleep. The term West syndrome is basically a triad which indicates an electroclinical syndrome consisting of epileptic spasms, hypsarrhythmia on the EEG or its variants, and concurrent developmental delay. So if all these 3 things are present, the patient is diagnosed to have West syndrome. But since many decades, it was recognized that not all children with spasms will have all the 3 things. So it was, and there were many children with infantile spasms who did not have hypsarrhythmia, but actually also had similar prognosis and needed similar treatment options. So in the ILA 2022 Diagnostic Framework Committee developed diagnostic criteria for all syndromes, they renamed West syndrome as infantile epileptic spasm syndrome. And I'll talk about how it is diagnosed based on those criteria. It is the most common developmental and epileptic encephalopathy. with a high risk of adverse neurodevelopmental outcomes, including developmental delay and intellectual disability. A high proportion of children develop autism and future epilepsy. The most important predictors of treatment of outcome are the etiology and the lag time to treatment. So it's very important that patients are recognized early and treated early, because early treatment definitely improves the outcomes. So what are the diagnostic criteria? The ILA, in its diagnostic framework, talks about mandatory criteria, alerts, and exclusionary criteria for all syndromes. So for West syndrome, the mandatory criteria as a seizure type has to be spasms, which can be flexor, extensor, or mixed, but occurring in clusters. EEG, hips arrhythmia, but is not all children will have hips arrhythmia, but in the presence of spasm, but even if the EEG shows multifocal or focal epileptiform discharges, we can still diagnose the syndrome and treat appropriately. Alert is a normal EEG, interictal EEG, or a suppression burst pattern, which usually indicates an earlier onset epilepsy, like an early infantile developmental epileptic encephalopathy, which was earlier known as Ohtahara syndrome or early myoclonic encephalopathy. Another definite exclusion is like clinically spasms are present, but the ictal EEG shows a normal EEG. So there's nothing on the EEG even during the spasm, then we can definitely rule out the syndrome. The age of onset is 1 to 24 months. Epileptic spasms can begin later, but this would not then be called as IESS. And so very early age at onset again is a red flag for this syndrome. And comorbidity, most commonly these children will have developmental slowing after the spasm. However, this may be difficult to determine in children who already have pre-existing developmental delay. MRI is not required for diagnosis, but highly recommended to know the cause. Ictal EEG is not required for diagnosis, but especially if the interictal EEG shows hypsarrhythmia or epileptiform abnormality. But if the interictal is normal, then one must obtain an ictal recording to prove this syndrome. And in some kids who are at risk, for example, infants with perinatal brain injury or a known malformation, or for example, tuberous sclerosis, patients who are at risk, they may show something called pre-hypsarrhythmia. That was basically EEG will show some high amplitude abnormalities, a high amplitude background, a background stroke, or multifocal. And this is a pre-hypsarrhythmia. And these patients should be watched carefully to see if they develop spasms, because they are at risk. But we cannot diagnose the spasms, IESS, till the spasms occur. And in low resource settings, even interictal EEG is highly recommended, but even if that is not available, if a experienced clinician has seen the videos of spasms, the syndrome can be diagnosed. In this is slightly kept kind of a looser criteria because it's so important to treat these patients. What is the etiology? So etiology can be acquired or genetic, and it can be classified as prenatal, perinatal, and postnatal causes. In prenatal are the majority. Genetic predominate. Genetic causes can be single gene abnormalities or microdeletion syndromes, chromosomal abnormalities, neurocutaneous syndromes, brain malformations, malformations of cortical development, intrauterine infections, fetal strokes. Perinatal is a large chunk of patients, especially in low resource settings. And in this perinatal asphyxia, neonatal hypoglycemia, perinatal stroke, neuroinfections, and a small chunk of patients have postnatal etiology, like a postnatal CNS infection, hypoxic brain injury, trauma. So when you see the etiological cohorts, they differ from the West as compared to the low resource settings. In Western settings, you will find an etiology 50 to 60% of patients, and genetic will generally predominate. Whereas this is a study we did nearly 12 years ago from my center, wherein we studied 148 children with West syndrome, and our major etiology, so 80% of them had the earlier terminology, it was symptomatic etiology for known patients, so 80% had symptomatic, and this has been replicated in many studies from the region. And amongst these, the major, most common ones was perinatal asphyxia, followed by neonatal hypoglycemia. So neonatal hypoglycemia, recent times, we are recognizing it more and more in the low resource settings. And this is the typical finding that they have bilateral occipital abnormalities. And in our study of 170 patients who had neonatal hypoglycemic brain injury and developed epilepsy, 3/4 of them had epileptic spasms. So this is like a huge problem, and that it is preventable. So that's why it's very important to talk about this condition, so that we need cooperation from neonatologists, gynecologists, obstetricians, so that this condition can be prevented. The other difference of the presentation in India and other low resource settings compared to the West is that these patients present late. So treatment lag here, people talk about treatment lag in weeks. The other treatment lag is several months. Most patients present like by 9 months, 10 months, even later sometimes. So there is obviously a significant treatment lag time from onset. This is important to understand some of the treatment strategies that we have tried in these patients. So suggested diagnostic workup is like everyone must have a MRI, preferably a 3 Tesla MRI. And then after this, like we first have to see if there's tuberous sclerosis complex. For tuberous sclerosis, one can just directly do a genetic testing or something very clear cut, say Down syndrome or something, some clear cut genetic etiology. Then according to that, the workup should be planned. But if otherwise an acquired cause is excluded by history and imaging, genetic testing, it must be done. And this depends on the resources, like one can do a microarray and an epilepsy panel, or go for whole exome sequencing or a whole genome sequencing. Most studies have shown the diagnostic yield of whole exome sequencing to be about 25%. So coming to the management, which is the crux of the talk. So the questions that I will try to answer with the evidence available is, which is the best first-line treatment available? We have options of hormonal therapy, vigabatrin, and combination therapy. And which hormonal therapy is the best? Is it ACTH or oral steroids? And after the first-line agents, what should we use next? So basically, there are two very well accepted first-line treatments. Hormonal therapy, which includes both ACTH and oral prednisolone and vigabatrin. The differences, like about in the previous century, it depended on where you were to see what treatment patients were receiving. In the US, it was ACTH, and ACTH by and large, whereas European countries mostly preferred vigabatrin as first line and maybe then would go on to ACTH as second line treatment. And the one major reason for this is vigabatrin was not there in the US. It got licensed only in 2009. In India, we always had vigabatrin, but it was on the gray market and it became licensed only in 2021, just like 3 years back. So it was difficult for patients when it's a gray market. You don't get insurance cover, you can't get billed for it, and it's again very expensive. ACTH also has different, there are different variants. There is a natural ACTH, the Actar gel, which was used in the US studies. And synthetic peptide, this tetracoxactide, was used in the UK. And corticotropin or synthetic corticotropin carboxy methyl cellulose, which is Acton prolongatum. This is the preparation that we have in India and Asia. There have been a wide variations in dosage across used across studies for both ACTH and prednisolone. So the overall trend in the last century was that ACTH was considered better, and the prednisolone doses which were used were usually the doses used in other conditions like nephrotic syndrome. So people would use like 1 to 2 mg per kg. So generally, ACTH was considered a more effective treatment. So and the questions that now we have is like, is hormonal therapy better or vigabatrin or combined therapy? ACTH or oral prednisolone and natural synthetic ACTH. So like I said, it was till the previous century, ACTH was considered kind of like the best treatment. And there are two things which changed that. The first was this landmark study, the United Kingdom Infantile Spasms of the UK study, which was published in 2004 in Lancet. So what the researchers had done was their main question was to see if hormonal therapy, which included either ACTH or prednisolone, was superior to vigabatrin. This was in a population where tuberous sclerosis was excluded. For tuberous sclerosis, vigabatrin is the medication of choice, so there is no question of questioning that. But in other patients, so this was their first question, and the study answered the question that hormonal therapy was definitely superior to vigabatrin. And they also did a subgroup analysis where they compared ACTH with prednisolone. And this was the first study where they reported high-dose prednisolone, used 40 milligrams per day. And if not responding, the patient was changed to 60 milligrams per day. And both ACTH and high-dose prednisolone had similar efficacy in this study. The other thing which changed the pendulum towards prednisolone was that ACTH simply became hugely expensive. The drug company Quest Corp suddenly jacked up the price of a course of therapy from $1,650 to $23,000. And now the other company which is acquired it still has $36,000. And even Dr. Sneed, there was a quote that he called this 2,000% hike on this treatment as predatory behavior. So obviously it had, of course, subsequently the company started covering, but it was really a time to look for alternative treatments. And when the study had come up, we also started looking at options in India because ACTH, though we had the synthetic ACTH, which was not that expensive, but still getting patients to have daily intramuscular injections, admitting them was difficult, or even outpatient, finding pediatricians who will administer these injections. So definitely oral prednisolone sounds like a good choice in a low resource setting. It's very cheap. It's an oral medication. The worry with the high dose was that this is a scenario with we had a lot of malnourished children, we had a lot of infections. Is high dose safe or not? So this was a study which we did nearly 10, 11 years ago, wherein we compared high dose prednisolone with the usual dose 4 mg per kg to 2 mg per kg, and we demonstrated that high dose was definitely more effective than low dose, and it was equally safe. So kind of with this experience, we were more confident, and other centers also started using high dose prednisolone with more confidence. Of course, this is not really as high dose. It's North America, people use 8 mg per kg per day. We still haven't got that confident in India. So the question of which ACTH is better, natural or synthetic, there is a huge cost difference between the two. And the study from Finland, they compared their own cohort of natural ACTH versus, they usually use a high dose for natural ACTH, synthetic lower dose. And they found that synthetic was probably as effective as natural. However, there is a kind of a systematic review comparing these. So there's no head-to-head comparative trial, but this comparative review found that maybe natural ACTH is a little better, and they say a number needed to treat for every 2 to 5 patients with synthetic, like one might do better with a natural ACTH. So again, probably they're reasonably equal. Maybe natural is slightly better, but there is a huge, huge cost difference and a availability issue also. So again, revisiting prednisolone versus ACTH, this study, the authors analyzed two cohorts, the UK-ISS and the international collaborative or the ICISS, which I'll soon talk about. They compared patients of prednisolone versus ACTH, and they again found that prednisolone and ACTH were equivalent for infantile epileptic spasm syndrome. And this was a network analysis looking at all first-line treatments done by Dr. Puneet Jain, my friend and colleague here at SickKids, and his team. And they found that ACTH and high-dose prednisolone were the most effective first-line treatment. So there is more than enough evidence now to say that this is more effective, and we have to use hormonal therapy. And ACTH and high-dose are equivalent. And given the fact that ACTH needs injections and most probably hospitalizations, and of course in Canada it is not even available for the last few years, so probably this discussion is all academic. But even to whether we even need to advocate it to get it, because probably we don't. Prednisolone seems to be just as good. And now we know that both these treatments, these are first-line treatments, hormonal treatment and vigabatrin. Does it make sense to combine these two treatments? So this was the ICISS study, International Collaborative Infantile Spasm Study, where they combined hormonal versus hormonal treatment alone. So hormonal could be either ACTH or oral prednisolone versus hormonal plus vigabatrin. And in the first paper they published in 2017, this combination therapy was significantly more effective at stopping infantile spasms than hormonal therapy alone. So this seemed like possibly we should do both together. However, just a year later, they had looked at the outcomes at 18 months, and they found that combination therapy did not improve either developmental or epilepsy outcomes at 18 months. And the only thing which actually seemed to improve outcomes that you treat early. Whatever treatment you give it early, and which people already knew. Rapid diagnosis and effective treatment could therefore improve outcomes, but there is no need to combine treatments. And in fact, now we have data that this combination could lead to more adverse effects. This is a very recent paper just published last month. People looked at vigabatrin-associated MRI abnormalities. So many times these abnormalities are asymptomatic, and then that's okay. They will go with the abnormalities in the basal ganglia and the dentate nucleus. However, some patients develop symptomatic MRI toxicity. This is associated with clinical presentation of encephalopathy, movement disorders. And when this group of children were analyzed who have symptomatic vigabatrin-associated MRI toxicity, it was seen that this is much more, the risk is much more higher in children who also had simultaneous hormonal therapy. So the combination may actually is probably not effect better than hormonal alone, and it can lead to more side effects. So a sequential kind of a treatment is better, that we first try hormonal therapy. If it's not working, then we try vigabatrin. And so there are three guidelines. So one was guideline which are, so this is from India Association of Child Neurology and IES guideline, where we reviewed all the evidence and did a whole Delphi, talking to the experts, trying to find out the best treatments. And there's a Brazilian experts consensus published, and also a guideline from the German Neuropediatrics Association. And all these guidelines roughly say the same thing. Like if there is tuberous sclerosis, go for vigabatrin. If it's not tuberous sclerosis, go for hormonal therapy, either ACTH or high-dose prednisolone. And German Society says that you can try combination therapy if you wish. If after 2 weeks you assess and patient is not responding, then go to the second line, which is vigabatrin. We also looked at the use of IV methylprednisolone because it seemed like maybe it's like a initial high dose treatment may have a better effect. And there's a couple of other groups that have looked at it, but really it wasn't more beneficial. And in fact, it led to hospitalizations, and some initial side effects were more like irritability, hypertension, were more in the methylprednisolone versus oral prednisolone group. So this was not really a better idea than giving oral prednisolone alone. I will talk a little bit about pyridoxine. Now, pyridoxine has been used a lot in Japan for the treatment of infantile spasms. And there are two ways we can consider pyridoxine. First is like in patients you don't know the cause, and while you're working up, you can give a pyridoxine trial that perhaps this could be a presentation of a pyridoxine-dependent epilepsy or a PLP-dependent epilepsy, and you give it to see maybe it works. And we used to do it too, but in our cohort of 150 patients, only one actually responded to pyridoxine. So, and this is a recent paper where they have looked at all patients with antigluten deficiency, the French cohort of PNP, PNPO, and pyridoxine-dependent seizures. And they found that none of them actually presented with a de novo West syndrome, right? So they said the presentation of this as de novo infantile spasms is so exceptional that it probably does not justify a systemic trial of pyridoxine. So they proposed considering a therapeutic trial for these vitamins if the spasms are associated with other seizure types or spasms start before the age of 2 months. So this is to be kept in mind, that we should not probably waste time. You give it for 3 to 7 days. In this time, you could have probably given steroids and got a better response. The other situation where you can consider is we tried it as a combination, because pyridoxine in Japan has been used like in the form of an anti-seizure medication because it increases GABA levels, so any cause of infantile spasms. And we thought that we will definitely give prednisolone because that is kind of the best proven therapy, but maybe we add pyridoxine and it leads to a better response. And actually, there's two studies, one from our center in Delhi, this is from PGI Chandigarh. We added it to prednisolone. They added pyridoxine to ACTH, and both were randomized controlled trials. But both trials showed that addition of pyridoxine did not really lead to any better efficacy. So it's really not a good idea to add. If patients who have failed the first-line treatments, one can still consider. If you still haven't got the genetics report and if you think you don't know the cause, it doesn't seem like an acquired etiology, that is one time you can consider. But if you, by that time, most probably by the time steroids and vigabatrin have failed, you may have the genetics report by then. After the failure of steroids and vigabatrin, there are a number of anti-seizure medications which have been tried. None of them are great. But there's evidence like some may be more effective, like generally topiramate, zonisamide. These have been medications tried for spasms, sodium valproate, benzodiazepines, especially nitrazepam. There's a lot of literature of nitrazepam for the use of spasms. Recent studies have also published use of clobazam, levetiracetam. There's a series of felbamate from France. People in sick, so Dr. Van Chow and Lindsay McRae, who they run an infantile spasms clinic, they have recently started using rufinamide based on the premise that spasms are similar to tonic seizures and rufinamide works in tonic seizures, and they have found some modest success in patients who have refractory patients who failed hormonal and vigabatrin. This from case series of CBD with some reasonable modest benefit, and a study of fenfluramine, which is ongoing. But after patients have failed hormonal therapy and vigabatrin, we need to do two things. The first thing is to see if the patient is an epilepsy surgery candidate. The second thing is, if not, or parallelly while you're working up for epilepsy surgery, consider ketogenic diet therapy, because this definitely should be considered after failure of hormonal therapy and vigabatrin. And because it is an effective treatment in these patients, it reduces spasms by more than 50% in about 60%, and about like 20-30% become spasm free. So definitely you have to try this treatment. There are certain concerns. This is a vulnerable population of patients who are young infants. They may have comorbid developmental delay, feeding issues. So feeding safety is an important consideration. So patients who are not, patients must undergo a feeding assessment. And if they are not found to be feeding safe, they should undergo a gastrostomy and G-tube feeding should be started. Things are much easier in Canada for these patients or in a low good resource setting where G-tube can be inserted. Ketogenic formula is available. So definitely this should be started, and one must start them on inpatient initiation because they are infants. And there are a few studies of first-line therapy as well. So one of the earliest studies was when, like I told you, ACTH became super expensive in the US. So one study from Johns Hopkins and Dr. Kosoff, they tried giving ketogenic diet as first-line treatment to a series of patients, and they seem to have reasonable efficacy, just as good as ACTH. And this is one study where they have combined, this is actually, they tried to do a randomized controlled trial of ketogenic diet versus ACTH, but many patients refused randomization. And so the next was according to parental or physician preference, either ACTH or um, ketogenic diet, and they combined both the groups. And ultimately, they found that there was no significant difference between KD and ACTH in terms of time to electrophysical remission, short-term remission, relapse rates, long-term seizure freedom. And interestingly, the ketogenic diet group had less severe adverse effects needing medical intervention. So interesting, but again, I'm sure most of us, that diet is a very high intensive, there's a lot of work involved in it. So one would definitely think before giving, comparing, like steroids are oral, they are difficult in the short run. They have a lot of side effects, but giving it for the diet is much, much more hard work. So first line, probably most of us would not use it. So what is the evidence for the use of diet? So this is one of the largest studies. This is not a randomized trial. It was a prospective control study. This is from China, where the patients who failed ACTH, they received either KD or like any other medication change. And patients who received KD had a much more significant reduction in spasms and hypsarrhythmias compared to this control group. And like in low resource settings, I said we have, remember, our patients had a late presentation. They would come at like 9 months, 10 months, and by the time they have failed steroids, ACTH, vigabatrin, maybe one or two anti-seizure medications, already like 1 year plus, maybe 18 months. So these kind of babies, because the diet for us, ketogenic diet is difficult for us. We don't have trained dietitians there. And we don't have formula. So we tried, this was a kind of a pilot study for the use of modified Atkins diet. And out of 15 children, we found that 6 had become spasm-free, which was very positive. And following this up in Lady Harding, we did this randomized controlled trial where we give one group got the modified Atkins diet as add-on, the other group continued their anti-seizure medications. Definitely the patients with the diet had, again, the 25% spasm freedom that is reported, which was definitely statistically significant. And this is a recent study which we finished a few months ago. This was modified Atkins because once patients fail steroids and vigabatrin, after that, the usual next line is topiramate. So we thought that we should try the diet is better or topiramate is better. So this was modified Atkins versus topiramate, a randomized study, and we found that patients with the diet had a better than 50% control and better seizure freedom. And because we did not use the definition of West syndrome, we used epileptic spasms, we looked at the EEG Bayesian score. So because you don't now need hypsarrhythmia to diagnose West syndrome, so how do you quantify the EEG improvement in therapeutic trials? You can use EEG scores, and this Bayesian scores is one of those scores, and we could demonstrate that patients, the diet group, had a better improvement in the Bayesian score as compared to the topiramate group. Colleagues from other centers in India have shown that the modified Atkins diet, they compared it with ketogenic diet in spasms. Again, one thing to keep in mind, these are older patients, not your typical patients Western scenario. They found that the diet MAD was as good as KD. And this study is from China, where it was not a randomized trial, but they compared patients who got the modified versus the classic diet in infantile epileptic spasm syndrome. So their patients also, the age at enrollment, median age was 12 months. So again, older. But they found that spasm control was similar in MAT with better tolerability and high compliance as compared to classic KD. And they've even said that MAT could be the primary treatment for children's spasms in China. So again, it depends on where the patient is. And interestingly, this is very interesting that this drug, tricaprilin, this is similar to triheptanoin, which you might know is an anaplerotic agent, which has been tried in GLUT1 deficiency. This is an investigational ketogenic compound. It is trioctanoin instead of triheptanoin. And this was a poster at the AES. This was tried in 8 patients with refractory infantile spasms, and patients did develop ketosis. This drug was well tolerated, and 4 out of 8 patients showed a reduction in cluster number and duration of spasm. So very promising, because diet, like I said, is a lot of hard work. This would just it will become a tablet instead of the whole diet. Now, moving on to the surgical evaluation, which is again, like I said, once we have failed the first line, we have to start thinking, is this a surgical candidate? And while we're doing that, we can try the diet. So focal structural pathologies are common but underdiagnosed. So like tuberous sclerosis complex, focal cortical malformation, Mogué, perinatal stroke, all these patients are potential surgical candidates, and we have to start looking for them. So their epilepsy surgery definitely has a role, big role. So although infantile epileptic spasms is a network disorder that affects the brain diffusely, it is frequently driven by focal etiology. And these focal etiologies, like I mentioned, include stroke, perinatal stroke, focal malformations of cortical development, TSC. And post-surgery, seizure freedom rates are 70 to 80% in children with well-defined lesions in the first 1 or 2 years, but they can decrease to 60% in follow-up. But prompt surgery, like any early treatment, is important for long-term cognitive and behavioral outcomes and lower rates of autism spectrum disorder. Greater neuroplastic potential of infant brains may afford better functional compensation following larger resective or disconnective surgeries compared to older children or adults. So this, again, is a very important population to consider epilepsy surgery in. This is the SickKids experience. Out of their 223 patients, 19 underwent epilepsy surgery, and what we found the most common causes, etiologies for these patients who underwent surgery was encephalomalacia, malformations of cortical development, and half of them underwent hemispherectomy. The other half underwent either lobectomy or lesionectomy. 3 patients underwent a second epilepsy surgery, but 80% were seizure-free at the most recent follow-up visit, and developmental outcome was also improved in 3/4 of the patients. So this is really very promising, and that's why we all need to consider it. What are the features which should prompt a surgical evaluation? So most of these patients will not have a very bad developmental delay. They'll be either normal or only mildly delayed. They may have focal seizures prior or concurrent with the spasms. And the spasms themselves may be asymmetric. So again, looking carefully at the spasm, a physical exam may show motor asymmetries like hemiparesis, early hand preference. They may have neurocutaneous stigmata or growth asymmetries. EEG may show asymmetries. I'll show some examples. And they may not respond, they probably will not respond to your first-line treatment. So they may respond and the seizures may come back. So this is one of the infants we cared for here at SickKids. This is a term baby, 1790 grams. She presented with spasms at 6 months of age. And you can see the MRI shows right hemispheric, there's white matter volume loss, there's some atrophy. And she had a mutation in the COL4A gene. So she probably had a fetal or a perinatal stroke. This was her initial EEG. So during the active epileptic encephalopathy phase, the hypsarrhythmia is usually diffuse. It is bilateral. So at this stage, you may see bilateral abnormalities. And so one has to definitely look at the EEG after the spasms have resolved, hypsarrhythmia has resolved, and then look at the EEG. Like in this patient, we saw the very right hemispheric posterior epileptiform discharges. So it's very important to look at the EEG after the steroids have been given or after the hypsarrhythmia resolves to see, are we looking at a focal pathology? So this was a nice paper by Dr. Moza and colleagues, where they described electroclinical features in epilepsy surgery candidates, epileptic spasms. And they described 3 kinds of abnormalities, like lateralizing, maybe right from the beginning, you know, that this is like a hemihypsarrhythmia or like totally on one side. It could be non-lateralizing, like the first EEG in the case I showed, but in the non-lateralizing, it's important to follow up after the steroids, after the hypsarrhythmia goes away to see if there are now lateralizing abnormalities. Or interestingly, they can also be false lateralizing abnormalities. Like in this case they describe, this is a patient with a big Scheissenkephlic cleft, and this is on the left side, but the EG is more prominent on the right side. And this is because typically you have a volume loss lesion like this with a big cyst. There's a lack of cortical tissue on the affected side. And when the acute epileptic encephalopathy phase, the abnormalities are usually bilateral, but because of the volume loss on this side and no cortical thickness on this side, the abnormality seems more prominent on the opposite side, paradoxically on the normal side. So this has to be kept in mind. And we have to review everything in context of the lesion, the EEG, the MRI. So MRI, as said, is the cornerstone of investigation. You need a high quality epilepsy protocol MRI at sequences like MP2-RAGE with improved detection of focal cortical dysplasias. And nowadays, like FCDs, MOGE, type 1, these and FCD type 1, these are important causes of spasm, but challenging to recognize in infants and young children because of the incompletely myelinated brain, which has reduced gray white matter differentiation. So repeat imaging when the myelination is complete is very important at 2 years of age. And the other investigation, which is most important, is the PET scan, because that will show regions of hypometabolism in FCD and MOGE. Though this hypometabolism can be very subtle in young children, so you may need qualitative post-processing techniques to identify. And just like in the acute phase with hypsarrhythmia, the bilateral abnormalities, initial PET scans can show bilateral hypometabolism. So if the suspicion of a focal pathology of focal cortical dysplasia is high, one can consider a repeat PET scan to see if there's any focal hypometabolism. And is there a role of MEG? So this is sick kids data from Dr. Hero's group. So this is a very early study published in 2008. This is older patient with spasms, but basically they looked at MEG clusters and they demonstrated that MEG clusters actually overlap the atrial onset zones. And once you resected the MEG cluster, definitely the patients had a good seizure-free outcome. And at sick kids here, we would do a MEG for patients with spasms in whom we're planning epilepsy surgery to look at this. This is a very recent systematic review we looked at epilepsy surgery with epileptic spasms. They looked at a total of 531 patients in 21 studies and a pooled seizure freedom rate of 70 or nearly 70%, which is very good. And resective surgery results in seizure freedom for majority of patients. And patients who undergo hemispherectomy have a lower risk of recurrence than patients who undergo other types of surgical resection, like lobectomy or lesionectomy. And increased duration of spasms prior to surgery is associated with increased risk recurrence. So again, early treatment. Time is of the essence with the developing brain. And one systematic review of Dr. Robin Whitney and colleagues here at Sick Kids and other centers in Canada. This was corpus callosotomy for refractory epileptic spasms. So basically, they did see, they reviewed all the studies and they did a meta-analysis, and they found that can be an effective treatment option for selective individuals. And sometimes after the callosotomy, it can guide further epilepsy surgery. What about precision medicine strategies? So these are like the precision medicine is like the hot new topic with epilepsy nowadays and even in spasms. This is we need to consider. So one thing, so in tuberous sclerosis complex, with spasms, still the first line is still begabatrin. And mTOR inhibitors, though they are considered in many other complications of TSC, and the EXIST-3 trial looked at everolimus in refractory epilepsy. As of now, for spasms, they are not indicated for first line, but after failure of vigabatrin and maybe hormonal therapy, one can definitely consider an mTOR inhibitor in this group. If you find a treatable metabolic disorder like vitaminase deficiency or pyridoxine dependency, then definitely the particular supplement has to be used, and that is precision medicine in this setting. But of course, sodium channel blockers should be considered in patients who have gain-of-function mutations in SCN2A and SCN8A. Ganaxolone has been shown to be effective in patients with CDKL5-associated spasms. There's some experimental work on estradiol, neonatal estradiol for ARX, repeat expansion-associated Downs, infantile spasms, and GABA-B receptor antagonists. But this is still mouse model work. And gene therapy is coming up for Dravet and maybe many other gene mutations in the future. We're going to come. This is going to come up in a big way. But precision medicine, main precision medicine strategy to be remember that even epilepsy surgery is a precision medicine option. And there is a known etiology like a focal cortical dysplasia. This is a new drug, radiprodil. It works on the NMDA receptors, and this recent paper combines both the preclinical and the clinical data. So preclinically, it showed prominent anti-seizure effects in juvenile animals, and also it was tried in 3 infants. And these 3 showed good safety and good pharmacokinetic profile, and one of them became spasm-free. The other had significant reduction in spasms. Can we prevent spasms? So one is this, people have looked at it in tuberous sclerosis complex. So the EPISTOP trial, what they did was patients who were either antenatally diagnosed or diagnosed at birth with tuberous sclerosis complex, they were followed up with serial EEGs. And once they developed epileptiform abnormalities, they were started on vigabatrin. And it showed a positive result that at 24 months of age, they had reduced risk of clinical seizures, reduced risk of drug-resistant epilepsy, and infantile spasms. So another larger study was done, the PREVENT trial, looking at the same things, but also looking at cognition, neurocognitive outcomes, not just epilepsy. Sadly, it also showed that there was a later time to onset and lower incidence of spasms, but overall, it did not improve neurocognitive outcomes. It did not delay the onset of focal seizures, drug-resistant epilepsy, because all treatments have their side effects. Vigabatrin does have field effects. One has to consider the risks with the benefits. And so in a scenario of perinatal asphyxia or maybe like a known malformation, this is another, like we also tried following up our babies with perinatal asphyxia and neonatal hypoglycemia to see if we can identify at a prehypsarrhythmic stage and intervene. Unfortunately, for hospital-born babies, we never got so many patients prehypsarrhythmia to actually study this. This is a trial I found in clinicaltrials.gov. No results have been published. So this was a trial for patients who are at high risk, and they're looking at patients with a prehypsarrhythmic EEG and give them low dose ACTH to see if the EEG improves and they don't develop spasms, but no results are published yet. For the developing countries, one of the major preventive strategies are definitely going to be improve perinatal care and prevention of neonatal hypoglycemia. So to conclude, infantile epileptic spasms are the most common TEE, and the etiology is myriad. Basically, it's an age-dependent epileptic encephalopathy. So any brain problem or any genetic neurocognitive problem or a structural brain, perinatal insult, postnatal brain insult can lead to this particular syndrome in this vulnerable age group. So early diagnosis and prompt treatment are very crucial to improve outcomes. So we have to see how we can improve. Some of the strategies could be like for all high-risk babies to teach parents what spasms look like, maybe improve like in well baby visits, immunization visits for these babies, especially to see, again, check for spasms at each visit. We may not be able to do, it may not be feasible to keep continuing sequential EEGs in these patients, but at least the clinical spasms people should be taught to recognize, help both healthcare workers and families. And once they're recognized, first-line treatment, I think we have enough evidence now that hormonal treatment is the first line and high-dose prednisolone, followed by, if it's not working, then try vigabatrin. Second line, of course, please evaluate for surgical candidacy. And focal lesions should be, which are amenable to surgery, because early surgery improves outcomes. But all other patients who are non-lesional, bilateral, genetic, likely genetic, or awaiting surgery, unless there's a specific contraindication, they must be evaluated for ketogenic diet therapy, and precision medicine therapies are in the pipeline. So I would like to thank all my colleagues who work with me in the studies, and my mentor, Dr. Aneja, and patients and families. And thank you very much for this opportunity.